We're going to go ahead and advance rapidly to our panel discussion, which is going to be led by the eminent Dr. Michael Saag from the University of Alabama at Birmingham. And then our panelists, if you could please come on up. We have the speakers from today, and we also have additional panelists is Dr. Carlos Del Rio, who's a world-renowned expert in HIV care and prevention and chair of the Department of Internal Medicine at Emory University. And some other of the speakers that you haven't met yet would be David Wiles from Denver Health at University of Colorado and Denver, and Rafi Landowitz, who's the chief of the Division of Infectious Diseases at UCLA, who's an expert on HIV treatment and prevention also. I'll turn it over to Mike.
Great, thank you. All right. So the way I've organized cases historically and today is to think about a clinical question and then tailor a case, sometimes based on a real case, but it's mostly just kind of stylized to get to the critical test question in a clinical context, and then create answers that are plausible, but usually with one correct answer. Sometimes there's more than one, and we'll discuss that, but the idea is to think about what's new in the field and what are some common challenges we have, and working through it with a panel who can often disagree with one another, which is kind of fun to watch. And so that becomes your entertainment for the next hour. So I don't have any financial conflicts. We're going to talk about people starting ARV therapy. We're going to go back to the weight gain question in a practical way. Hepatitis B co-infection, which you'll hear more about from Dr. Wiles later, but we'll dig into it a little bit now. He's going to be talking about mostly cure. This is on a more practical level. Pre-exposure regimens that have failed, bacterial vaginosis, skin lesions and fever, and heart failure. So quite a mix. So we always start with this one. What regimen should I use as initial therapy? This 48-year-old person who's recently diagnosed, and the viral load is high at 280 and the CD4 count is kind of low. Other labs are normal. You end up with a genotype back before you actually make your decision, and it's wild type. No prior medical history, renal function's normal, and he wants to start therapy. So which of these regimens would you choose? I'll let you peruse them, and we'll have a conversation. All right, so 94% go with the Biktarvy, but a smattering of others. Who wants to kick this off? Maybe Dr. Del Rio will pick on you first, and you can walk us through this.
Sure. I mean, I agree with the audience, right? I mean, Biktarvy or TAF-FTC is the easiest choice. It's one pill once a day. It's what we would use in this individual to start with. I think there's several reasons why this next choice, C, the dolutegravir 3C, I wouldn't start. And one of them, there are many, but one of them that David would talk about is we don't know the hepatitis B serologies on this individual. So before you did that, you wouldn't like to know that. And then it's interesting, you can go to cabotegravir direct to inject, but nobody wanted to do that. And this is where you said, what regimen would you choose? And I think that's more what regimen would the patient choose. If the patient were to say, I want to get the injected drug, then what would you do? And assuming cost issues and other access issues and other issues, I mean, it's a potential possibility in somebody who, if you had the drug and the person wants to go that way, but most of us will go with Biktarvy or TAF-FTC as the initial treatment.
Rafi, any thoughts?
Well, the only thing I would just add to what Carlos was saying is, remember, and Dr. Lennox talked about this a little bit, is, right, we don't actually have regulatory approvals at this point for cabotegravir and rilpivirine in people who are viremic, right? You have a wild type virus, so in theory, it should work, and we have a bunch of cohort case series level data sets that suggest that this may be a reasonable thing to do, but there are ongoing clinical trials right now that are in the field that will definitively answer this question for us. And of course, what I'm talking about is, right, cabotegravir rilpivirine right now you have to get somebody suppressed to undetectable before you use it according to the package insert. I think we've all been in situations where the ideal person for an injectable regimen is not someone who's already suppressed, it's someone who's struggling to suppress. And the most recent update to the IAS-USA 2024 guidelines suggests that if you know there isn't resistance to either agent and you have someone who is unable, unwilling, cannot take an oral regimen, and they have low T cells, as this person does, and is at risk for opportunistic infections and other complications, it may not be an unreasonable, that's double negatives a lot, thing to do. But just remember, that is not the current regulatory approval.
Melanie.
If I could just weigh in that, for the IAS-USA guidelines, really we're talking about people who, not newly diagnosed individuals, but people who have been on treatment for a while and are unable to maintain viral suppression for whatever reason it is, having had some support. But also, as Rafi said, people with low CD4 counts who really are at risk for disease progression if we don't help them out. So, I think this person who's coming to clinic for the first time, I would probably not go in that direction. Let's put them on something. I also would choose the single tablet regimen just because it's easy and because we know it's going to work if the person is able to take it.
And Mike, if I could add that you cleverly didn't give us any past medical history, so our choices would vary depending on whether the person was taking PrEP and which PrEP they were
We're
taking.
going to get to that.
Hang on.
Cleverly. Darcy, any thoughts? What if we change the case around? Because I don't have a case on this year. Last year I did. But let's say this was a 26-year-old woman, newly diagnosed, 6 weeks pregnant, as part of routine screening was found to be HIV positive, and you're going to start therapy. Do you have any strong feelings about which of these regimens you might use or not use?
Yeah, I don't. I think I would agree with the audience and probably go with BF-TAF in terms of some of the other options, Cadryl, Pivirine, dolutegravir 3-TC, and pregnancy would not do. And there are emerging data where we see that there's both safety and efficacy of BF-TAF in pregnancy. And of course, if they were already on that, I would continue that as well. So I don't think from the options listed here that it would change the answer, but an important consideration and something that we often forget to think about and check for when we're meeting patients for the first time of pregnancy potential.
Yeah, I think a big change between old days and meaning last year and now is that dolutegravir TAF FTC has really been the gold standard, but the recent data show that BIC-TAF FTC works as well, and the safety is emerging so that it's probably is a co-equal choice. That's a changing paradigm. Okay, then we already mentioned the guidelines from IAS-USA. They came out in December. They're in JAMA if you want to look them up. They're also on the IAS-USA website, which is a great resource for you, by the way. There's all kinds of these sessions are recorded, and you can replay them or refer colleagues to them. And the CME for that, I believe, is free, or it's very low cost. So you can always go to the website, look for all kinds of materials.
And Mike, I think when you look at these guidelines over the years, and when you've been at this course coming for so many years, you realize that the questions many of the questions remain the same.
Absolutely the same.
The answers are just different.
Absolutely. So that's the reason to do it. And that's why we keep having this course. And so how you answered 2 years ago might not be exactly right today. So let's go to Darcy's topic here. How do I manage weight gain? This is now making her talk into the real world. A 47-year-old woman started on BIC-TAF FTC because 94% of you started her on that. Her initial HIV RNA was wild type at 28,000. CD4 count was relatively high. And her viral load now is suppressed, and she had a robust CD4 count response. But since starting a regimen, her weight has gone from 155 with a BMI of 27 to 187 with a BMI of 32, and she's very concerned about this. Fasting glucose was in the pre-diabetic range, as was her hemoglobin A1C, or fairly close to that. So anything besides diet and exercise, which of course was part of your talk, would you do anything else at this moment? No other interventions, change your ARV, start metformin, refer for bariatric surgery, start semaglutide, or some other option. Let's go ahead and vote. And the semaglutide would be ramped up if you choose it. You're not just going to start with one. But let's go. All right, so you've convinced a lot of people, Darcy, to start semaglutide right away. Would you do other things first? What would you do?
I think usually this decision is sort of something I want to do and then what I actually can do related to a lot of the constraints that we talked about earlier. Usually in terms of starting GLP-1 receptor agonists like semaglutide, you have to have documented a 3 to 6 months trial of diet and exercise, but that's not always the case. And so if I had a patient that was very motivated and I could get this covered, then I would definitely try and get it started while also doing dietary and exercise modifications. As we kind of talked about, I wouldn't change antiretrovirals, and referral for bariatric surgery would sort of have to be a discussion, but seems like there are less invasive things to do. And, you know, this person does have indications by BMI alone above 30, but also has some comorbidities in terms of some evidence of insulin resistance. So it would be a really good candidate for this medication and intervention, and I think could have long-term benefits. So I would try to get it started and do the ramped up dose as you mentioned.
Yeah. So what typically happens now, getting to the real world, and this came up a lot in the Q&A, if most insurance companies probably would not just release semaglutide, they want to say, did you try diet and exercise? Did you try something else? Some require metformin up front in this setting. If there's other comorbidities, heart failure, sleep apnea, as you mentioned in your talk, those things kind of fast track. But not having much else going on, we probably wouldn't get it approved right away. So you'll be fighting that fight for about 6 months or so, and you just got to go for it. What about bariatric surgery? I don't think you talked about that. It's something that was used a lot for folks with BMI over 40 historically. Are folks still doing that, or are they going to the GLP-1s first?
I think it really depends on where you're practicing and what you have access to, and also then sort of what the patient preferences are. So I think that in centers where they have weight management centers of excellence and they have a multidisciplinary team, including surgical colleagues, you can refer patients and have sort of this comprehensive evaluation, but that's not available everywhere. And so in places where that sort of multidisciplinary and sort of surgical expertise maybe isn't as readily accessible, trying to get medications is also something that's being pursued and seems like they're maybe equally difficult or have different barriers in terms of trying to get access to these things. But I think patient preference is going to weigh in heavily here as well. Obviously, bariatric surgery is a major intervention, so wanting to take that into account as well.
Right, and generally they won't.
Mike, you pointed out the difficulties of overcoming the reluctance of some insurance companies, and some patients to bypass that reluctance are getting compounded treatment through compounding pharmacies. I would be interested, Darcy, do we have any data on the efficacy of compounded agents and how reliable they are?
I haven't seen data on it. If other people know of it, please let us know. But I haven't seen data, and I talked about sort of the caution in terms of not really having the regulation and sort of knowing what you're getting. So that's, I understand the motivation for pursuing that route because there are so many barriers that are imposed by the system, but there could also be significant safety issues that come up.
I have to say that I checked into a compounding pharmacy that was recommended to me because some of my colleagues were using it, and the first thing I found when I Googled it was that the FDA had issued a warning to them. They had inadequate quality assurance. They didn't have expiration dates on their drugs. They didn't have quality control measures. So, you know, I think I generally don't recommend compounding pharmacies because who knows what people are getting. People do it anyway without my recommendation. They go online and they get stuff. And so I think we just have to follow them closely if that's going to be the case. And, you know, I don't judge people about that, but I think we have to have a heightened sense of awareness.
Okay, this one's going to the far end for Dr. Wiles, but should I check for Delta hepatitis D virus in my patients with chronic HBV? So, 48-year-old guy presents. It's basically the same guy as before, except he had started on dolutegravir, TAF, FTC. Other labs were normal. His surface antigen is positive, antibody negative, but his E antigen is negative. So should I test for HDV in this setting in a person who's a PWH? Let's go ahead and vote. David.
All right, so we've got a pretty even split here. The short answer is yes. You know, in the United States, hepatitis delta is pretty rare, but persons with HIV would be one of the groups where it would be recommended to screen for delta if they have a positive surface antigen test, so indication of hepatitis B, active hepatitis B infection. And just to mention, that screening test would be a hepatitis delta antibody, not the antigen. We get frustrated at our institution anyway when you type in hepatitis D, the first thing on your list is the antigen test, which is not what you want to use, and so we're wrongly coercing folks into doing the inappropriate test, but it would be an antibody. So that's where we stand. You know, it's much more prevalent in folks from other parts of the world. So part of what you'd like to maybe know just to look at risk would be, you know, where is this patient born in the United States or outside the United States, and where were they from?
So the incidence among our patients with HIV is about 5% or so?
Or lower. And we have a lot of issues. One, it's not routinely tested, so there's not a lot of great data. And some of the kind of retrospective analyses probably have a lot of bias if you look at centers that are kind of really attuned to hepatitis B or hepatitis in general, or persons with HIV probably test more, and maybe have patients that are at higher risk that kind of are in their cohorts.
Okay, so the next question here, you test the antibodies positive, I don't know if you get an RNA or not, but antibodies positive, treat them with bulevirtide. Let's go ahead and vote. One of your questions might be, what the hell is bulevirtide?
Yeah.
But we'll talk about that. I guess that's not sure if you vote.
Yeah.
All right, most people aren't sure. Let's educate us, Dr. Wiles, because I know
Okay.
you probably aren't getting to that in your talk.
So not sure actually might kind of be the right answer here, just because you don't have a lot of other information. So first, bulevirtide is a subcutaneous injection of a peptide that blocks the hepatitis B receptor, and so the virus can't enter the cell. And by blocking hepatitis B, you also block D, because hepatitis D uses hepatitis B surface antigen in its coat, and that's how it attaches to the cells as well. So one, you can't have D without B, that's active. And then the therapy you use is blocking the entry of both viruses into hepatocytes. So that's how it works. Part of the issue is bulevirtide is not FDA approved in the United States. It was approved in the European Union a couple years ago, and was brought forth and not approved, not for necessarily efficacy issues, but more manufacturing stuff, kind of like we initially had with cabotegravir kind of based regimens. So you couldn't just write a prescription for it anyway. There is a kind of expanded access or compassionate use program. But that would be limited in the United States to folks who had cirrhosis along with their hepatitis delta infection. So it's a pretty complicated process. Again, as I alluded to, it's a sub-Q injection daily. And we don't really know how long somebody would be on it once you started it. It's kind of indefinite therapy because there is the risk when you stop of a flare in somebody with cirrhosis. So it's complicated. You would need to monitor. I have one patient on it, and they're not living with HIV.
Right, so these two questions are linked in a way, at least in my mind, that if you find someone, they test positive, what are you going to do about it? And then if you just test and archive that result, at least in my practice, even though you have an EMR and you can find it, you got to start searching pretty hard if it was done 3 or 4 years ago or longer. And so my view is I wouldn't necessarily test for it now unless and until we have therapy. And then I would think about the person who would be eligible for therapy, as David just said. And that's the person to test because you can do something about it. So I'm typically not testing for D.
I think that makes sense, Mike. The only thing I would say is if you do have a patient you have identified and you know they have hepatitis B, and say they're on their HIV therapy, let's talk about somebody with both infections, and you're suppressed their hepatitis B DNA, but their LFTs are still really high, that is somebody you should think about looking for delta in, because that is one possible explanation. The more likely thing might be metabolic liver disease. And then if somebody had cirrhosis is the other, I would certainly screen, because there really starts to potentially become a life-saving, even if temporizing intervention.
Yeah, good point. Well, that's the discussion I wanted to have. All right, something that flips back to a way to Dr. Lennox's talk. Can I start long-acting ARV in someone who's HBV positive? So 48-year-old guy, this is the same guy basically. So I do that on purpose because you don't have to reread the case, you're already oriented. Wild type now he's doing well and he wants to switch to long-acting injectable ARV. His HIV RNA is less than 20, his CD4 count is 270. You can't find a hepatitis B result in the chart, or maybe it was 5 or 6 years ago, and you want to sort of see where their status is, and you get an HBV result. Which of the following is the signal that says you should not start an injectable, or you should just not start it anybody who has any evidence of HBV? Okay, 61%. This was one of your questions pre-test. And about the same proportion got it right. Not exactly to the 70% passing, but this was one of the more positive answers that we got. David, I'm going to pitch it back to you again and see if you have a way to explain this.
About is that DNA mean undetectable? Just they don't have Hep B DNA?
I'm sorry?
The DNA option that says less than.
Yeah, it's positive, but it's not quantifiable or something like that.
Okay. So I would include that patient as well, probably if they had hepatitis B and DNA that was detectable. But maybe flipping it around and saying, it would be I would say it would be fine to start somebody that was positive surface antibody. I think the core positive antibody, Melanie alluded to this a little bit too, is probably the most interesting scenario and potentially the most confusing.
Right.
Because they've certainly been exposed to the virus. But if you only had the core antibody, there have been, we're all aware of the case reports in series that have looked at this. Probably it's 2 reminders. Oh, here we go. But one that, first of all, tenofovir analogs are great prep for hepatitis B. So in somebody that's never been exposed but's not immune, we certainly see cases of new infection. It's been somewhere around in the isolated core positivity, around 1%, maybe 2, or even less in some series that haven't shown it. So that's where I think it's maybe more controversial, and I think you have to look at kind of the patient and how strong their preference is to go to a long-acting injectable, what their risks might be, and then certainly checking their vaccine status again to make sure you've got them up to date, and a higher, tighter surface antibody, I would say above 100 is what you really want.
Yeah. So that was the point of the question. I think the take-home point is that if somebody's antigen positive, and especially if they're antibody negative, you probably don't want to switch that person as a rule. However, if they're core antibody positive only, a lot of folks nowadays are just saying, give them Hepaslav, take them through a full series, get the hepatitis B surface antibody present, and then you should be good to go. And that's kind of the practical take-home point you can go with. Last year, I think I asked the question about isolated core, and it was a big shrug and nobody knew, but I think over the last year, the notion of vaccinating, especially with the Beehive data coming out being so strong, and converting, and I think that might be the way forward. Okay, what should I use as initial therapy in the setting of PrEP failure? I think this came up earlier. We have Dr. Landovitz on the panel. Let's see what he has to say to this question. 28-year-old guy presents newly diagnosed with HIV, has been on cabotegravir every 2 months for PrEP, has not missed a scheduled dose. That will become important. And his last dose was 2 months ago. He's asymptomatic, HIV detected by routine antigen antibody test per Dr. Landovitz's recommendation. HIV RNA is kind of lowish. You could make that 1,200 if you want, whatever you feel. We'll have a conversation. No other labs are normal. The other labs are normal. No prior history, normal renal function. Okay to start therapy. In fact, quite anxious to do that. Which regimen would you choose in the setting of PrEP failure with cabotegravir monotherapy? Go ahead and vote. All right, Dr. Landovitz, walk us through this. This is kind of complicated, but I wanted to make sure. I knew you were on the panel, so this is a great opportunity.
Yeah, three things. First of all, guilty as charged. I've seen Rent 72 times. Second of all, let's first answer a question that wasn't asked here. Let's suppose you have someone who's on tenofovir-based PrEP and they acquire HIV. What's the right regimen to start with? The answer is your same first-line regimens with 3 drugs that you would use otherwise, probably a dolutegravir or a bictegravir-based 3-drug regimen is fine. Why? We know from Nadia, 2SD, and the DEFT study that even in the worst-case scenario, K65R, M184V, you can treat people to suppression in incredibly high proportions with that. So it doesn't matter. With tenofovir-based PrEP, you're still going to use the same starting regimen. Cabotegravir, different, right? What you're concerned about is integrase resistance. And the reason Dr. Saag was highlighting that he had not missed a scheduled dose, and every time Dr. Saag presents me this case, I say, you're not actually telling us the information we need to know. You tell us he didn't miss a dose, but were all his doses on time?
Yeah.
Were they?
Yes, of course.
Okay. So in the clinical trials, the context in which you see integrase resistance is when somebody has been on time with all injections and they get HIV anyway. It's a very rare occurrence, but when it happens, that's when 100% of the time you have integrase resistance. So you would not probably want to treat this person with a bictegravir or a dolutegravir containing regimen, at least not initially. Their viral load is kind of low. I probably would start with a boosted PI-based regimen, get them to undetectable for some period of time, and then I might consider, particularly if there was intolerance or drug-drug interactions, switching to a bictegravir or dolutegravir interaction. During the clinical trials of cabotegravir, everyone was wringing their hands, oh my God, the tail, right? The long pharmacologic tail. That's going to generate integrase resistance. What happens if they get it during the tail? Then it's going to be harder to treat. Turns out that's completely incorrect. When people have late doses, when they get HIV during the tail, you do not get integrase resistance. So the guidelines actually say if it has been more than 6 months since the last injection, when you find the first evidence of HIV infection, then it's probably going to be wild type. So then your answer A, the bictegravir or dolutegravir regimen, probably just fine. But it's the unique circumstance of when somebody acquires HIV, rare, with on-time injections, that's when you have to worry. So I would not probably use a BIC or dolutegravir.
So the other question is, has Dr. Landovitz seen this question more than he's seen Rent? And it's close. Real quickly, just for fun, you might want to explain why you saw Rent so many times. It's not like he had $150 a visit.
Nobody
right?
cares.
Nobody cares. Okay. He was in Boston
Come
as a
find me
resident.
at lunch. It was therapy when I was a medical intern.
And you can get in more or less free if you just put your name in a lottery, and he kept doing that and kept going. He also played the role of Mark in the play for a month and a half and was very good at it. All right, how do I manage a woman with bacterial vaginosis? 35, this is also one of the pretest questions. 35-year-old cisgender woman followed by you. She's monogamous, diagnosed 10 years ago with HIV, well controlled on BIC-TAF FTC, history of recurrent bacterial vaginosis. Other STI screening has remained negative. Which of the following regimen would you prefer to employ? Metronidazole orally, metronidazole gel, clindamycin cream, tinidazole, or one of the oral therapies, and also treat her male sexual partner, her husband. Go ahead and vote. All right, 65%, a little better than the pretest. Anybody want to take this on? Carlos?
Yeah, I mean, I think bacterial vaginosis is, I guess people can make a history of their, Ginny Marassa actually started her research doing bacterial vaginosis. That's what she works on. And it's, it's a very difficult disease to manage, frequently very frustrating. But what we've learned is that it's really important. Whatever regimen you use is really important to treat the partner. And well, that's something that it's come pretty clear. And the study you're showing actually, again, reinforces that, right? That the treatment of the partner makes a big difference.
So this was a controversy, or has been a controversy in
For
the
a long time.
Go ahead.
Yeah.
Okay.
Yeah, keep on going.
It's been a controversy in the STI world for 2 decades.
Yeah.
Do you treat the partner in bacterial vaginosis? And the guidelines, which were published, I think in 2022 or 2021, said, no, don't do that. They went ahead and finally did a very well-controlled randomized trial published last month early in the New England Journal that shows, as you see here, that treating the male partner is important for actually decreasing recurrence. And it was current and new, and we don't, we talk about STIs, but we don't talk about bacterial vaginosis that often because we hadn't considered it as directly as an STI, but that's the news flash, it is. So that's the take-home point. David.
Mike, I'm going to learn something here. How important do we think the topical portion of this treatment might be to preventing that recurrence? Do we know the topical clindamycin used here?
No, that was just a guess, I think, on the part of the, So they treating both topically and orally was part of the regimen, so I think that's what we were obliged to do till proven otherwise.
Yeah.
Well, and I would just say, practically speaking, and maybe it's different in your guys' areas, but we don't have access to the 2% clindamycin. And so I don't know if people have been able to find that to use for the topical treatment, but when we've talked about rolling this out in our clinic, that's been the missing piece of figuring out how and where to get that. So I don't know if other people in different states maybe have access to that or.
Yeah, minor trivial details.
And while you're at it, we don't have 400 milligram tablets of metronidazole either, so there's that.
Right. But we do want to use the oral treatment, metronidazole, twice daily for 7 days is in the guidelines.
Yep. Okay, so how do I manage new skin lesions in an outpatient setting? This 30-year-old male presents with new lesions on his buttocks, groin, back, and face. He's sexually active, reports fever, anorexia, asthenia, failure to thrive. His HIV has not been well controlled. He's been intermittently compliant with his ARV therapy. His UDS was positive for methamphetamine, and he's sick enough to require hospitalization. And these are the lesions that are totally consistent with Mpox. Now, this is picking up on Dr. Lennox's CROI review. So what are you going to do? You're going to give him tecovirimat, cidofovir, brincidofovir, going to vaccinate him, or just supportive care? Go ahead and vote. This is a tough question. Yeah, this would have been an easy question prior to CROI. Most people would have used tecovirimat and we'd have moved on. But now we have a randomized trial, a little bit underpowered, but fairly convincing in the sense of not non-inferior, is that the right way? Or, whatever. It just didn't work.
But also consistent with the results of the other clinical trial.
Yeah,
Right.
yeah.
There's been two clinical trials that show that tecovirimat is not beneficial for Mpox. So we wish it were true, but it is just not true.
So if wishing made it so, what are you going to do, Jeff, in this setting? This guy's not he's not critically ill, he's not in the ICU, maybe supportive care at this point. The vaccine's not going to work too well at this point. But let's say he's sicker. Let's say he's so sick he goes to the ICU. What would you do then?
Well, if there's a clinical trial open, I would
Yeah.
probably enroll him in a clinical trial of a couple of other antivirals that are being tested.
Fair.
You know, the brincidofovir probably has little impact
Yeah.
based on the data available. And clearly, pain control is really what patients benefit from the most and other supportive care. But, you know, people are hesitant to give people the narcotics they need when they've got severe mpox, but it can be incredibly painful.
Other thoughts, Melanie?
I would put him back on his antiretroviral therapy.
Yeah.
I mean, I think
Good
this is
point.
one thing that's the first thing that comes to mind. You know, you saw the data about people dying who have HIV and low CD4 counts, and, you know, obviously, it's important. His CD4 count isn't below 50 now, but it will be very quickly. And so getting him back on his antiretroviral therapy, I think, is the most important supportive care you can give him, in addition to pain control and all that.
So my personal approach, if he were starting antiretroviral therapy, is important, of course. But brincidofovir, for those of you who aren't familiar, is a prodrug orally bioavailable of cidofovir. But if the person's going to the unit, there isn't much data for use of brincidofovir. Cidofovir is going to be the most potent approach. Now, those of us who have more gray hair remember and have experience using cidofovir for advanced CMV and occasionally for acyclovir-resistant herpes. And people are a little bit cautious when they use it because they're worried about renal trouble. If you follow the package insert administration rigorously and you give probenecid ahead of time, that drug can be used for quite a while very safely without renal insufficiency. When you get into troubles, if the staff haven't kept up with the probenecid ahead of time, and then the kidneys can go south. But rigorous hypervigilant use of probenecid and following the hydration rules and all that, cidofovir I think would be a great choice for him if he were going to the unit. Otherwise, antiretroviral therapy, pain control. So it was a great discussion. So how do I manage heart failure? This 41-year-old guy presents with progressive dyspnea on exertion, doesn't have PND, but does have two-pillow orthopnea, meth use. Diagnosed with HIV 15 years ago and persistently undetectable, doing well on a dual regimen of dolutegravir 3-TC, and CD4 count is good. Heart rate shows a regular rhythm, not tachy, slightly elevated JVP and a soft S3, trace edema. Renal and liver function are normal. He's on amlodipine for hypertension. He's a former smoker, but he quit 5 years ago. An echocardiogram, it almost makes the physical exam meaningless, doesn't it? I hate that because I love the physical exam, but what is his ejection fraction? 35 to 40%. That tells you what you need to know. Normal wall motion. So out of all these drugs, which do you think is the most important to start? Understanding you may start more than one. What do you prefer here? Go ahead and vote. All right, so a lot of folks like Entresto or Lasix or some SGLT2 inhibitor. Melanie, in your practice, primary care a lot, what would you do here?
I don't think referring to cardiology is a punt. I got to say. I mean, this person, I think, needs a cardiologist. And so I work closely with cardiologists, have my favorite cardiologist. I would get a cardiologist involved, but the treatment for reduced ejection fraction heart failure is going to be multiple drugs. And I think spironolactone probably preferred over Lasix, but an SGLT2 inhibitor, the Entresto, beta blockers. So it's a complicated situation, but I think generally multi-drug therapy is used. And, you know, I think it's also a complicated situation because this person is going to be starting multiple drugs. And I think it's important to take that into consideration. And, you know, right away, the person has polypharmacy, even if they're only on one drug for their HIV. And polypharmacy is a risk for all sorts of other bad things. So I think it's really important that we take into consideration the challenge of starting multiple new drugs, follow that patient closely, talk with them about potential side effects, be sure they know in advance what the side effects might be so that they don't get discouraged and stop taking the drugs and end up in the ER. So.
Right. So this is, go ahead.
I was just going to add, you'd also be totally within bounds to consult cardiology because you'd want to do sort of a comprehensive workup, ischemic versus non-ischemic cardiac disease to potentially change your intervention. And I would add maybe a referral, or in addition to F, refer to cardiology, like ask a current intern or trainee since they sort of have this down pat because they do
that's
this.
the reason I still do, seriously, I still attend on general medicine at UAB. I do. And the reason is precisely that reason. I learned from the house staff what's new. And one of the things I have to keep up with is how in the world you categorize heart failure from HFrEF, HFprEF, HFmrEP. I can't even pronounce it, but I just called it heart failure, you know, and now they got all these modern kind of things to say. But this is true combination heart therapy, right? Mm-hmm. And I don't feel competent managing that. So when you're 4th and 30 on your own 10-yard line, it's appropriate to punt. That's a good thing. One of the things that was great at Croy that Jeff didn't have time to cover was Matt Feinstein from Northwestern did a wonderful review, and you can get it online almost about now. Yeah, it's been 30 days. So all the Croy presentations are available. It's probably in the next week, free to you. So this is one to look up, in my opinion. But he had a nice mini lecture on heart failure, why it's complicated. That alone tells you need to get the cardiologist involved. But there is a higher risk of heart failure in our patients with HIV. We're going to be seeing more of it not only as people get older, but it's something that the management is quite refined now. I'll say it's complicated, but they really have nuances. Almost certainly this patient is going to have a cardiac catheterization because they're not going to start throwing drugs unless they know what the anatomy looks like. They'll be able to look at pressures. There's all kinds of things that they do that we don't, and otherwise we're kind of treating blindly. And digoxin, you know, love it, but measure levels, but it doesn't really work as well as these other ones. Maybe use it if there's an atrial fibrillation and you're trying to block.
Digoxin is the AZT of cardiology.
It's what?
The AZT of cardiology.
Yeah, that's right. It's AZT, Zadovudine. There you go. This is a study that he reported from the Scenics group, but you can just see that there are multiple risk factors that pop out when you do multivariable analysis from hypertension, diabetes. It's pretty much what you would expect intuitively, but having numbers and relative risk associated with these variables is a real helpful thing. We're just going to be seeing more of this over time. And then the classification, here comes those HFrEF, HFprEF, HFmrEF. Anybody know how to pronounce that? And then etiologies, non-ischemic only is about half. And ischemic only for someone this age is not going to be that common as you would anticipate. Meth use is obviously a risk factor for type 2 MI, which happens. Cocaine, same way. So this is something that we're just going to have to be mindful for. I look at all this as a backhanded compliment to antiretroviral therapy. The fact that we're dealing with ordinary, if you will, medical problems that affect all people is a real tribute to the fact that we've got HIV managed in a lot of people, and now we're going to have to be internists again, our family docs, and that's really important, primary care, which is why we had that topic this morning. All right, what do I do with someone who has an M184V mutation on a cellular DNA assay? So this is a made-up case, but it's fun. A 65-year-old who got transferred to you for evaluation, who was diagnosed 28 years ago. Originally had about 1 million copies and a low CD4 count, multiple prior regimens that you don't really know because they weren't kept carefully. But right now, he's on dolutegravir, 3TC, and abacavir. And his viral load is suppressed. They switched him over, they dropped the abacavir, and he's still staying suppressed at the dolutegravir 3TC dual therapy regimen. Viral load's 35, CD4 count now is 25. You don't have any historical resistance tests, and he doesn't recall an incident of virologic failure. During the routine visit, you're out of town, but your colleague who's covering for you ordered a DNA genotype, and it comes back with an M184V. What are you going to do? So stay the course, change wouldn't be prudent, not going to debt. Dolutegravir 3TC or restart the abacavir, stop it and go to BIC-TAF FTC, or fire your colleague who ordered that test. Let's go ahead and vote. Let's see what we got here besides the wrong. All right, stay the course, change wouldn't be prudent. More than half. What do you guys think? I see a lot of head shaking.
I think that fire the colleague who ordered the DNA genotype test is the appropriate answer.
And that's exactly what happened. No.
Because you've got to suppress viral load. Everything was beautiful, life was good, and somebody ordered this test. And what do you do with the results? I mean, you're going to change their therapy, which is always traumatic to somebody if you're going to do something about the results. And if you're not going to do anything about the result, don't order the test. So studies have shown that the predictive value of a positive 184V mutation in somebody who's got a suppressed viral load, it does not predict subsequent failure.
Yeah. So this question was sparked by a conversation I had about 6 weeks ago with one of the nurse practitioners I work with, when I said, we're having the Atlanta course coming up. What are some things that you're wondering about that you struggle with? And she said, I don't know what to do with DNA resistance tests. And I said, that's good. So I had to create a scenario where it didn't add much and it kind of screwed things up. So I made up the case. But you get the picture. There's an article in press right now in CID, keep your eye out for it, from the IAS-USA mutations panel of the resistance guidelines folks, okay? And it's about DNA testing. And the punchline is, it can be helpful, but it's more often confounding. And the reason is the nature of the test itself, and they go into some great detail about why. One of them is that there's a natural enzyme that all of our cells have that's designed to protect us against viral infections, and it's called ApoBec. And ApoBec, when it's encountering a virus that has been integrated into our genome, starts to mess with that virus and causes hypermutations of adenosine and some other things that really change and alter the genetics of the virus, oftentimes creating stop codons where the virus is no longer viable. The problem is it's really hard in a DNA assay to know what was amplified in a small region is really a viable virus or not. So that's a first problem, is kind of the specificity of what does the mutation mean. The second is sensitivity, because it could miss something that was there. So when you have a test that's that kind of precarious, there might be a situation where it's helpful, but my experience more times than not is that it makes me scratch my head and wonder why I ever ordered the test.
I mean, Mike, would it be useful in somebody who's failing a current regimen and is, like this patient, failed multiple previous regimens? Your regular genotype's going to detect your current failure. Mm-hmm. Would it be useful to order a DNA genotype thinking about, well, what about the prior failure?
I don't do it in that setting. You know, there might be a situation where it's clear someone's on the brink of virologic failure with a viral load of 300 or 400 and not quite enough to get amplification to do a plasma HIV RNA genotype. That might be a situation, but that's kind of rare. Carlos, I think you were going to say something, or no?
No, I was going to say that this case, reminds me of when Melanie and I were in residency. The chief of medicine at the VA was Joe Hardison, and she frequently would ask you, when you order something stupid, what'd you do that for? And that's what I would ask my colleagues here.
And then you got fired.
Yeah, but I mean, again, when you order a test, know why you're ordering a test and know what the consequences are going to be. And sometimes, there's so many times that we order all sorts of tests, and we are more puzzled after the test than before the test.
So how many of you are puzzled about when to order an HIV DNA genotype? Yeah, I certainly am myself, so I don't order it that often. Okay, last case is actually a real case. I've even got more updates on, but it is kind of a throwback case for those of you who are relatively new to HIV medicine and didn't live through the sort of older days of lots of opportunistic infections. This was a case.
Well, courtesy of the new administration, that may change.
We might be headed there. 35-year-old man who's followed by you, diagnosed 1 year ago, literally almost to today, with new HIV infection. He was admitted with fever, chills, anorexia, failure to thrive. He got co-diagnosed with PJP and MAC. We see that. And the lymph node biopsy showed the MAC, and it was loaded with organisms, as it usually is. His viral load was over 1 million, CD4 count was 7, got treated with BIC, TAF, FTC, trimsulfa, azithro, ethambutol, rifabutin, and improved. 6 weeks after that, he's initially feeling really good. It's like you feel like you did a miracle. He's coming back at 3 weeks, and it's like a new guy, gained weight and eating well, all that, and you're celebrating. And then about 3 more weeks after that, 6 weeks total, he starts getting fever again, and he's diagnosed with IAS. So you start steroids, and again, you feel like you did a great job because he comes back 2 to 3 weeks later, and he's feeling great, and his parents are with him, and everybody's excited. But then he got lost to follow-up. Not sure why. And then he returned, it's probably about 7 months ago, and he kind of got back into care. He restarted his meds and felt better, but for the last 3 months, his fever, anorexia, abdominal pain, which is kind of new, came up, not necessarily due to the constipation. Viral load is suppressed because he's taken his medicines. The CD4 counts come up kind of nicely, but his white count is 21,000. White count, 21,000. With a left shift, an abdominal CT shows lymphadenopathy with necrosis in the middle of the node, but the size was unchanged. Numerous, the lymph node biopsy, needle biopsy, negative for malignancies. It had lots of AFB, and the cultures are sterile. His LDH, I'll give you this, was normal, like 220, not elevated. So, what in the world is going on here? I'm pretty sure I have an answer, so I'm not just going to leave you hanging. Let's go ahead and vote. Okay, so what do you guys think? There's a number of folks who've been dealing with HIV on the panel a long time. What are you going to do? You're going to change his, like the audience feels strongly this is recurrent MAC. Some people think it's recurrent iris. Some people think it's a bacterial superinfection, occult malignancy. All these are possible. What do you guys think?
Well, when you said he restarted his meds, did he restart all his meds, including his MAC drugs?
Yeah, he restarted his MAC therapy too.
So you really don't know this, and now you got a biopsy on somebody who's taking MAC therapy. So it could very well be he has a recurrent MAC. It could also be recurrent iris, right? Because he also restarted his antiretrovirals. I mean, he could he had recurrent MAC, started his drugs, and now he has recurrent iris. And what you're seeing is a combination of both.
Right. So we're about out of time. I'll just cut to the chase. It is a very interesting case, and I called Irina Soretti at NIH And she's, to me, the person who's had the most experience internationally with IRIS. And the reason I was scratching my head so much was I couldn't make sense of the high white count, because you don't usually see that with IRIS. You might see a leukemoid reaction with TB, or you might see it with lymphoma, but I'm not used to seeing that with MAC directly, and I'm not used to seeing that at all with IRIS. And she said she's seen some cases, not a lot, who had a leukemoid reaction during an IRIS spell. My thinking is that even though the biopsy showed AFB, that somehow these organisms remain in the tissue but are not viable. So they're likely dead organisms, although we don't know that for sure. But if they were viable, that biopsy should have had enough material to grow. MAC's not a hard bug to grow. It usually grows. And if it grew, we could do resistance tests and all that. But without the growth, I'm leaning heavily towards this being IRIS. But this is a type of thing where even people that have had lots of experience, there's still cases that make us scratch our heads and think. And to me, even though the case is challenging, this is part of the challenge, but also maybe in a backhanded way, the fun, if you will, of thinking through problems and trying to come up with solutions that help
Well, and the
people.
challenge, Mike, is did you start this patient again on steroids again with that white
Yes,
count? Yeah.
that's the plan. And he's currently in the hospital, and the teams are sort of hesitant, and I'm kind of going, go.
But
Yeah.
Mike, the other thing is, right, the culture results aren't going to come back immediately, right? So you're going to have to make a clinical decision, particularly if he's hospitalized right now. And I think what I would do would put him back on MAC, put him back on his ART, Melanie, yes, of course. I know what you were thinking. But put him back on MAC treatment while implementing steroids.
Correct, he is. That's exactly what he's going to do. The part that I left out that was new last week is that CT scan showed what looked like a large collection of purulent material. ENT and thoracic surgery came in and drained it. The regular bacterial cultures are sterile now a week later, maybe 8 days later, and the MAC is not growing despite the stain being positive. And that wasn't out of a lymph node. And the low LDH, for those of you who are wondering about lymphoma, I've never seen a case of lymphoma with this degree of pathology that had a relatively normal LDH. That just doesn't.
But Mike, would you still push for an open biopsy? Because you alluded to this, right? We don't love an FNA for ruling out malignancy.
So that was what we were pushing for, and then they stumbled onto this thing, and they still haven't gotten a full node. But yeah, so that's just the reality. I don't usually show real cases, but I thought it'd be fun to discuss. So conclusions are, art therapy should be initiated with an integrase inhibitor-based regimen unless otherwise indicated as close to the time of diagnosis. Weight gain is associated with almost all the antiretroviral therapies, but especially INSTI and TAF. And one of the questions that came in, we talked about this, but I think got missed, was changing regimens doesn't really help with weight gain. It certainly doesn't induce much weight loss, so that alone is not enough. And not something we typically would do. Chronic HBV co-infection with a surface antigen is a relative contraindication for a non-tenofovir-based regimen. Bacterial vaginosis is an STI, and both partners, especially with recurrent disease, should be treated. Mpox has limited treatment options, sadly. Use non-INSTI in treatments where CAB failure has happened and the patient has been getting their doses on time. That's a really important subtle concept that we teased out. Unclear what to do for HDV co-infection in the current era. Heart failure is common and can be complex. Use your cardiology colleagues. And cellular DNA resistance tests in general is not that helpful. So I think we'll close. We have a few questions here that we can go in. Can Delta be active in doing damage if HBV DNA is non-detectable?
Yes.
Easy one.
And frequently is, or they kind of inhibit each other. So if delta is high, the B viral load tends to be low, even not on therapy.
And then I think you alluded to this, but when co-infection B and D are together, there is more rapid progression to cirrhosis.
Yeah, quite rapid, actually. I mean, like within 10 years,
Yes.
a lot of times they
So
can progress to
it is
cirrhosis.
something kind of know about, but that's why you said watch the liver enzymes and keep an eye on them clinically.
Mike, there's a audience question.
Oh,
at the
sorry,
microphone.
hey, come on.
Hey, Brian Perlman, Atlanta. Thank you. Very informative. I disagree with you, Dr. Saag, and I don't do that lightly about the hepatitis Delta co-infection, because these folks, as you just said, have a higher rate of progression and a rate of higher hepatocellular carcinoma. So my suggestion is not to ignore it. Test for the nucleic acid. If it's positive, strongly consider every 6-month HCC screening, even if you don't have confirmed cirrhosis. And I'd still be on the lookout for that.
HPV.
For HPV.
Yeah.
Right. But the point is, the Delta makes it a higher risk,
Yeah.
much higher risk, whether
Right,
it's
for
progression or
hepatocellular.
cancer, right?
Yeah.
Yeah, go ahead.
Right, we're supposed to be doing that anyway, right? Regardless of D.
Yes, that's correct. I would tell the patient they have a much higher rate of, even higher risk.
It's, yeah.
Yeah,
it's
and
a
I would
good
try to
point.
get compassionate use
No,
if
no,
it were
no.
advanced.
I
Yeah,
see.
Right.
Okay.
So that's it. And it's HFpEF and HFrEF, by the way, and it's not that hard. It's
No,
systolic
but
or
there's
diastolic.
an MREF now.
Right,
That's what I
improved
said.
EF when the
Yeah.
EF goes up. And that's my second point. I disagree with the punting to cardiology. You guys are able to do complicated CART regimens with multiple drug interactions. I don't consider goal-directed medical therapy for systolic heart failure very hard at all. And you're saying we should be internists again, and I strongly agree. If anything, that would buy a catheterization when I send them to cardiology. So I disagree. The meds are pretty darn good.
So that's good, it's good. Reasonable people can disagree, and it depends on your own personal practice, and we can go, yeah, I'm not in disagreement.
And I would suggest that when you make those complicated decisions, you should be paid equivalent to a cardiologist.
And the whole reason I refer is that I'm not paid equivalent. All right, and then are there studies that look at bioavailability of HIV medicines due to possible decreased absorption due to gut wall edema in patients with episodes of decompensated heart failure? I don't know if studies in that, maybe it happens in general medicine where some drugs aren't well absorbed, but it's something to keep an eye. I haven't really heard of cases of virologic failure due to edema in the gut. I mean, we know about drug-drug interactions with divalent cations. We've had cases like that here before.
I would also say that, patients who have heart failure of any kind are often able to maintain virologic suppression. So I don't know of any data, but I think for the most part, people can maintain their virologic suppression in all sorts of degrees of heart failure, sometimes very bad.
And then are there recommendations regarding giving vaccinia IVIG in severe mpox cases? I know that it exists, and I know that you could probably get it, and I suspect it's doable. I don't know the answer, to be honest.
We had a case of ocular mpox, and so we were on a call with, of course, local and then national CDC, which who knows if that will be available in the future if you have to consult. But that was something that came up in terms of discussion as a possibility that would be helpful given the severity and kind of sight-threatening experience with the ocular mpox case that we had.
Right.
And this is not for nothing, as my wife's relatives on Long Island say. I know that one of the fatal cases was given a couple courses of IVIG with high titer, anti-vaccine antibodies, and it didn't seem to have any clinical impact. But, we don't know. There hasn't been a clinical trial, right? If somebody's in the ICU dying of mpox, you might try some things that you don't know what the evidence will eventually show.
Okay. Well, thank you very much, and we'll take a break for lunch.